I'll go on to our last speaker, Dr. Viral Shah, who again is a senior consultant at Meenakshi Eye Hospital, Nagpur, and specialized in anterior segment and phaco surgery. And more importantly, a very dynamic and a very popular person from Nagpur and for Vidarbha State Society. I do remember a very nice trip when I had come to Vidarbha conference and was so well received. And I look forward to watching Dr. Viral Shah's video.
Thank you, madam. At the outset, I would like to wish a happy Mother's Day to all the lovely ophthalmology ladies that are with us today afternoon. Thank you to Dr. Chitra madam for giving me this opportunity. Thank you to AIOS and ARC committee. So I will be speaking on hypermature cataract, suprahard with a milky fluid. The case profile in brief: a 78-year-old female was mild hypertensive, dense white hypermature cataract. Vision was PL and PR accurate. IOP was 18 mm of Hg. Other I had a pseudophakia, operated 10 years back in a camp. Not much documentation. ECC was done. So whenever I see such cases, my preoperative pearl number one, it starts with preoperative preparations. Cataract like this. So my SICS set gets autoclaved, my ECCA set gets autoclaved, my vitrectomy set is ready, my SFIOL is there, a 3-piece lens is there of the same power or the one diopter less, the iris claw lens is there, tricot is there, iris hooks, CTR, everything that I may need is ready before we take the patient into the OT. So I will play my video. Just, yeah. So as I mentioned, preoperative preparations is the first and foremost pearl from my side. Second is anesthesia. Always I give some 3 to 4 cc of peribulbar block because of anticipated increased time in surgeries, anticipated complications that may need more maneuvers that may be needed. This is a no-brainer. We always have to stay in such capsules where it's total white with some fibrotic strands seen in the anterior capsule. OVD always use some high whisk and dispersive and cohesive wicks like a soft shell technique when you also use. So always keep the AC formed. So I started the Rexis. Initially, I thought that it will be a simple case, but as I took Rexis for one quadrant, suddenly I hit a milky fluid pocket and the AC was flooded with milky fluid. So this is the step, pearl number 5, decompression. You have to aspirate this intralenticular fluid and put down the intralenticular pressure, and again you have to recompress the AC with viscoelastic and form the AC and flatten the anterior capsule before proceeding further. So this is pearl number 6 from my side, reforming the AC with OVD, flattening the anterior capsule. So again, we start with continue with our Rexis. Here you can go with either cystitome or you can enter the AC and use your Rexis forceps also. I decided to go ahead with my cystitome since I was able to see the Rexis margin clearly. A slightly lesser Rexis than I had planned for, but I was confident that I would be able to do phaco from this, so I didn't enlarge it at this stage only. Gentle or minimal hydroprocedures. Just a little hydroprocedure can be done just to check about the nucleus, get a feel of the nucleus and whether there is any radiations or not. Now for phaco nucleus management, you have to have appropriate parameters for phaco. These are very hard brown cataracts. So we need a very high power with a low aspiration, slightly lower aspiration, so that you get a good hold on the nucleus to crack it. So try to crack it as much as possible in the bag. So I'm going able to get the first crack. So I proceed. Then it becomes a bit easier. So I divide the nucleus into 6-7 pieces inside the bag only. So after emulsifying most of the nucleus, managing the last nuclear fragment. This is the most important, one of the most important pulse. The last nuclear fragment, there is no epinuclear sheet there to protect you. So you have to be very careful. You have to do a slightly phaco in a slow motion, or you can remove the other instrument from the side port. So the AC gets deepened for a fraction. You can assess it better, and then reintroduce that side port instrument and again form the emulsify the rest of the nucleus. So putting in the IOL and the last pearl is you have to stop and review as much as you want to do. Take your time, review the case at each step and proceed further as per the case allows you. So that is the end of the case.
Wonderful video, Dr. Viraj, and really, truly excellent surgical skills shown. Only thing, maybe the rexus could have been enlarged following the IOL implantation. I think I do not have any questions as to about the surgery as you have done it exactly the way it should be done. But supposing a person has a challenge in cracking the posterior plate, would there be any tips or tricks Dr. Chandrasekhar, Dr. Swapna would like to give? How would you all go about it? In those very leathery posterior cataract, would you actually go and end up doing a stop and chop and breaking up into two halves?
Yeah, stop and chop.
Please.
Yes.
Stop and chop is one nice way to go. Yes. And I'd like to put in the instruments deep into the cleavage and separate them laterally way back at the posterior end. Yes. I mean, rather than, pull them open like that at the anterior portion, go down and separate, at the posterior end. So this reduces both the maneuvering, the amount of pressure you're putting on the zonules, as well as gives a full break. Now, in case you end up with a flower-like picture at the end of the day, then you can always flip that up and eat into the posterior part also, but that is more risky. So I prefer the first part.
Yes, Dr. Chandrasekhar, anything different?
Yes, shifting to stop and chop is definitely one thing on the mind. But before that, I would like to chop rather than taking a chopping and eating piece by piece. I would like to chop all of them first, because sometimes the chop does not extend right onto the other side, and then you can have a tilting of the nucleus, and sometimes you are left with a central disc. And if you get central disc, then the chop can be visualized directly, and you know that you are going in the right direction.
The best parameter to keep is to try to see the phaco reflex, the reflex from the retro reflex, so that you know how deep you have gone and whether that's adequate to start the chop while you trench.
Yes, while talking on femto cataract in an intumescent cataract, I'm going to ask Anaga only to answer this question. What would be the challenge you would, how would you deal with it? What are the challenges you expect when you're doing femtosecond laser, LRCS?
Yeah, here many times what happens is, if there is a lot of milky fluid, the moment you start the femtosecond capsulotomy, because of the leakage of the fluid, there is a shallowing of the chamber. So the margin normally, which would be around 500, you can enlarge it to say 700 or 800, so that you have a good capsulotomy. But in spite of that, and many times the nuclear dissection is not really very good in case of white cataracts. So we should not expect too much of, even if you have done a softening, it may not really have helped. But always stain the capsule, even if it is a flax patient, number one. Secondly, expect that there will be some areas which have not been cut in spite of us having seen, even though with the catalyst system, it's very fast and before even the milky fluid can come out, you're done. But still there could be some tags. So you need to stain it and see, and then very gently complete it if it's not cut completely.
So Anaga believes in increasing the offset which is from 300 up to 300 down.
Yes.
So Swapna, would you also want to increase the offset? Ramurthy, would you also look at increasing the offset? Because it makes logical sense.
Yeah, because there are a lot of undulations in the capsule. So yeah,
Yes.
that makes sense.
Yeah.
I personally don't do that. I mean, both the Lensex as well as the this catalyst platforms and even other Lensar and other things all work on the principle of contour guided capsulotomy. So basically the OCT itself recognizes where exactly the capsule is. So even if it's slight tilt is there, obviously if subluxated, it's different, but otherwise it compensates for those undulations. And when you make a standard 300 micron offset, both anterior and posterior to the capsule, anterior capsule, then usually get a adequate rhexis. Of course, as Anaga said, you can get a posterior stamp. It's not always a free floating rhexis. It's a good idea to stain and separate it. And it is the same reason that even when it's a PPC, I don't increase my offset from 800 microns to 500 microns, 500 to 800 microns, because the OCT takes care of it and doesn't really touch the posterior capsule.
So the point was that it's not a dynamic OCT, and as the fluid escapes, the level of the capsule changes. So to cover for that change in level is what I think.
Yeah, that's what I also meant.
There are 3 questions which have come up, and there are some more, but anyway, I just rapidly, we just 2 minutes, we'll answer this. Would reverse optic capture of a square edge lens produce iris chafing and pigment release?
That's always a compromise in the sense, any square edge, whether it's in the haptics or the optics, if it is in the sulcus, it's not a good idea. So it is a compromise.
And sudden constriction of pupil during hydrodissection in a planned phaco. What all could be the reason and how to go about it? One could be the constriction, could be the pupillary snap sign, which is what he means. Or this could also be something like, when you see in a high myope, there could be because of the elasticity of the sclera, and there could be a sudden meiosis of the pupil.
No. Iris retropulsion syndrome, you get a dilatation. You don't get constriction.
You get a dilatation, yes. Yeah. So what else could be a reason? Anything which strikes to your mind which we could answer this young doctor?
No.
Direction of fluid, bringing the iris, causing the iris to bellow up or something?
No, it's basically bellows up, then it would dilate, because it's the loss of the stretch that causes it to constrict. That's the reason that the pupillary snap sign
happens in a high myope.
Sorry?
I think this is some characteristic thing which could happen in a high myope, that sudden pupillary meiosis and dilatation, for which
in a high myope, it happens, ma'am, when you put fluid under the iris, that is when it constricts. But in a high myope, during retropulsion, the anterior chamber deepens, the iris lens diaphragm moves backwards and the pupil dilates. But if you put your fluid under the iris, then it would come up and constrict.
Yes.
So
that could be probably one other reason for the meiosis. I couldn't think of any other answer. And of course, the other question is anterior capsular tear, how to proceed further. I think one has to be just do a very careful, if you're going to do, either you are a beginner surgeon, you should convert at that point, or if you are a careful surgeon, I suppose you would have to look at the extension of the tear, whether it's everted or inverted, and looking at that, do a careful phaco, directing your phaco forces away from the area of the tear, and keep in view that the tear does not extend. And if possible, you could even bring the pieces supracapsular and go ahead and complete the case. And when you plant the lens, it should be away from the direction of the tear. Anything else we have missed out which you all want to answer for this?
Always inject viscoelastic before removing the irrigation.
Yes.
So that it doesn't extend posteriorly.
Yes.
And Dr. Rohit Omprakash has explained very well that
Yes.
flutter of the anterior capsule, that when the air has gone to the posterior capsule, there is no flutter. But as
Yes.
long as it is fluttering, it means that it is still not reached the posterior capsule. And that's a very, very important
The
sign.
direction of the flutter, if it is upwards then and downwards.
Just
Yes.
stop.
Upwards is safer. When it
Yes.
becomes inverted, it means it has gone back.
Yeah.
Wraparound rexus, wraparound tear. So I think it has been a very exhaustive 3 hours, and I truly believe that if not for this amazing expert panel, we could not have gone through very well. And I'm truly thankful with the speakers also this time for their very energetic contribution during the course of the meeting. And I'm truly thankful to one and all of you, the top class expert panel, and with their answers and the very great set of speakers. Very interesting videos, such variety of topics which are covered. I'm sure all of you enjoyed these 3 hours as much as I enjoyed it. And I think we need to definitely thanks to Anagha for being that the constant, stable moderator whom I knew would always come out with a question in case I falter anywhere. And thanks a lot to my ARC team and Satyajit for being a superb talk which he gave, and of course always being a major support for me. And so are the other ARC people who incidentally are not there at this point of time. And I think we need to thank the AIOS admin team and Mr. Kripal for sending those prompt SMSs, and of course Sai and Manjula from Numerotech for all those amazing, the way they crowd your mailbox at all time. I think today morning there were 3 mailers from me, if any of you did see the mails. And I wish to hear a good comment from you all about our interesting ARC video which I had shown. I would be very obliged if you all have something favorable to say. I don't know how many of you saw that ARC video which I had sent on the email. If you have not seen it, please go back and see it and send an encouraging comment so that we do even better in the next 1 year which is left for us. And finally, I think, of course, very deep felt thanks to Entod for being those great sponsors for all our programs. And finally, and most importantly, I think we need to thank attendees. It's their presence and their numbers which encourages us to keep coming back to you all with more and more webinars. Thank you very much, one and all of you. Thank you.
Thank you. Thank you very much.
Thank you, everyone. Thank you, ma'am.
Thank you, all of you. Thanks, Dr. Abhijit, Dr.
madam.
Asal, Shail, all of you.
Thank you,
Everybody.
madam. Thank you.
Thank you.
Anand Sethi, thank you very much.
Yes. Anand Sethi. Oh my God. Dr. Anand Sethi. So sorry I missed you out. Thank you so much
Thank you so
for
much.
being such a major support at all times.